I'll start by introducing Dr. Amanda Cecino. She grew up on the East Coast of Florida in the Palm Beach area. She attended Boston University, where she studied biochemistry, molecular biology, and neurochemistry. Wow. At that time, she did research in neurosurgery department at Mass General Hospital on Parkinson's disease. She then came home to Florida and completed her MD, PhD at the University of Florida College of Medicine. Her PhD is in neuroscience, and her focus is on pathogenic mechanisms behind Parkinsonism. She completed her neurosurgical training at Johns Hopkins Hospital. Additionally, she completed 2 spine fellowships, one in Hopkins in robotic and minimally invasive spine surgery applied to spinal oncology, deformity, trauma, and adult congenital diseases. The other fellowship was at the Swedish Neuroscience Institute in complex and minimally invasive spinal surgery. She is a member of the Neurotumor Board at Johns Hopkins Hospital for the past 4 years. She and her husband, Dr. Gregory Canarsa, who is also a neurosurgeon, just located to Naples, and they've started a practice in neurosurgery together called Apex Brain and Spine. Please join me in welcoming Dr. Amanda Cecino to the podium. Thank you.
Can everybody hear me okay? So good morning. Today I wanted to speak broadly about where things are right now for treatment options for brain and spine tumors. As I'm going through this, just please keep in mind that decisions for treatment are not made solely by neurosurgeons. They're made, with input from radiation oncology and from medical oncology as well. So there are over 120 different types of CNS tumor. The easiest way to divide them up, obviously, is brain and spine, but also into primary and metastasis. So I'll start out by describing treatment algorithms for primary brain tumors, specifically glioblastoma, which is the most common malignant brain tumor, and meningioma, which is the most commonly diagnosed brain tumor overall. Then I'll speak about metastatic brain tumor treatments, then primary spine tumors, specifically ependymoma and chordoma, and finally metastatic spine tumors. So in terms of prevalence of primary CNS tumors, in the age group of 15 to 39, they are the most prevalent form of cancer. And then as we age, the prevalence of primary CNS tumors decreases, but that's due to the increase in metastatic disease. Patients with metastatic diseases are living longer now due to better systemic treatments, so a larger portion develop mets to the brain and spine. And I recently just wrote an article about this in the CCMS newsletter. So although the algorithms will vary slightly depending upon the type of tumor, because this can be very nuanced, in general, there's 3 categories of treatment for CNS tumors, and that's surgery, radiosurgery, and systemic therapy. So in terms of surgery, there's 2 main advances that I'll show examples of. The first is the use of robotics and augmented reality to help minimize tissue disruption so patients can heal quicker and can shorten the time from surgery to radiation and systemic treatment. The second is the use of invisible closure, particularly with brain tumors. So it used to be that when somebody got brain surgery, everybody could tell by looking at them. But now with the invisible closure, patients come out of surgery and it can be difficult to tell that they even went. And this makes the patient feel better, and it also affects their treatment by hospital staff and by family and friends. And at least in our experience, they recover quicker. So this is a video. It's going to be highlighting a craniotomy and invisible closure. The Seattle Science Foundation, for those of you who don't know, is an organization that promotes physician-driven physician education. My husband and I have done a lot of work with them over the past year with talks at conferences. They're all on YouTube. This is a video that's going to be coming out soon of my husband actually clipping a brain aneurysm, but the craniotomy portions and the invisible closure are the same as with a brain tumor. So we wash the area, we make the part for the incision, and now we're just going through the scalp. And then this is obviously sped up. The craniotomy is done. There's the brain. And then you're under the microscope, taking the tumor out. When you're done, you're going to close up the dura. You're going to close up the area of the skull that you went through. And then this is just closing the scalp back up. And you can see that there's no suture that's left on the surface of the skin, and you wash the hair, and it's barely like we had ever been there. And so with radiosurgery, the evolution from conventional to stereotactic, in which a more focused, larger dose of radiation can be delivered, has really been revolutionary in care. This is just one example, CyberKnife, but there's many examples. And it's a potent tool when combined with surgery and also for patients who can't tolerate surgery. And finally, an area that's still evolving but has shown great promise is immunotherapy. And I think eventually this will take the place of systemic chemotherapies, which have a lot of severe side effects for patients. And when we resect tumor tissue in the OR, the sample goes to pathology and extensive genetic testing is completed. Tumors with high rates of somatic mutations have a higher load of neoantigens that are expressed on the cellular surface. And so that can really elicit a robust anti-tumor immune response. And the point of immunotherapy is to try to leverage that to make more targeted treatments for different cancer types. I won't go into a lot of specifics about this because that's really a whole other talk on its own, and it's reserved more for a medical oncologist. So currently, there is no curative treatment for glioblastoma, and treatment has really helped to improve survival. And in patients who receive treatment, median survival is around 15 months. And in elderly patients who just received supportive care, median survival is less than 4 months. The 5-year survival rate is 5 to 6%. So these are the most updated National Comprehensive Cancer Network treatment guidelines. The standard treatment starts with maximal safe surgical resection. This helps to reduce tumor volume and allows us to get tissue for tumor genotyping, particularly to check for something called MGMT methylation, because it helps predict response to one of the main chemotherapeutic agents that we use with GBM called temozolomide. And this is followed by radiotherapy, usually over 6 weeks with temozolomide, followed by another 6 weeks of temozolomide. And for patients over 70, hypofractionated radiotherapy means they get a lower dose over a shorter period. You'll see TTF up there, which means tumor treating fields. These are electrical arrays that are used in combination with the temozolomide for antimitotic therapy, and they've been shown to increase patient survival. There are no randomized trials showing survival benefit for repeat resection or repeat radiotherapy with recurrence. However, we will do it in younger patients with good performance status. In terms of chemotherapies, different agents are used. However, benefits are modest. There are a lot of ongoing immunotherapy trials, particularly at Johns Hopkins. However, the specific targets that have shown to be promising with other types of cancers like metastatic cancers haven't been as promising with GBM, unfortunately. So this was a gentleman in his late 50s who presented with a headache. MRI shows a large right temporal GBM. He underwent surgery. We were able to achieve a gross total resection. The molecular genetics for this patient, unfortunately, were not very favorable, but he did have that MGMT methylation, which allowed us to use the temozolomide. He recurred about 6 to 7 months after completing his radiation treatment and his temozolomide. We tried some other systemic treatments for him. We tried repeat radiation therapy, which did prolong his survival to a little over a year. So meningiomas are overall benign, but less than 1% are malignant. And these are the most updated guidelines for the treatment of meningiomas. And 2 things is it really depends upon the tumor grade or the histology and the degree of resection and surgery. So a couple of things on this that I want to point out. A lot of meningiomas are incidentally found on imaging. And if there is no mass effect on the brain and the patient does not have symptoms that can be directly correlated to the presence of the meningioma, then observation with serial MRI is recommended. Otherwise, the mainstay of treatment is maximal safe surgical resection. So in the top right corner, you can see a grading scale that we use. It's called the Simpson grading scale. And based upon the degree of resection, we can predict recurrence. So if a grade 1 Simpson resection is achieved, this is the best possible resection. This more than doubles the chance of progression-free survival, especially with high-grade meningiomas. For those that are a higher grade tumor, they aren't fully resected, which would be a Simpson grade 4. If they recur or if they're in an inoperable area, then the treatment is stereotactic radiosurgery. And meningiomas are chemotherapy resistant, so a little bit different than other tumor types. There have been trials looking at alkylating agents, tyrosine kinase inhibitors, anti-angiogenic agents, et cetera, which have shown little to no benefit. The next frontier currently being investigated is the response to immunotherapy. This may be promising in malignant meningiomas because they tend to have a higher number of somatic mutations, which I said is important for response to immunotherapy. And because generally the response is good in these patients, as you can see here, follow-up and serial monitoring is much more defined compared to GBM. So both these patients had grade 1 meningiomas, even though you can see there's a huge difference in the size. In the patient on the left, we were able to fully take out the tumor and any dural attachments. So this was the optimal Simpson grade 1. In the patient on the right, we fully resected the tumor to relieve the mass effect on the brain. However, we had to just cauterize the dural attachment to the falx. So this was a Simpson grade 2. And actually our PA, Liz Marinero, who came down with me from Hopkins, she helped me with the case on the right. So in the patient on the left, the recurrence rate is about 9%. In the patient on the right, it's about 19% over 5 years. So for both patients, there's just observation for now. They'll get follow-up MRIs annually for 5 years and then every 2 years. So the ratio of brain metastasis to primary brain tumors is 10-1. And there's certain types of cancers where screening for brain mets is recommended, even if there are no neurologic symptoms. And I list some of them there: lung cancer, stage 4 melanoma, and then some forms of breast cancer. The rest of them, workup is really recommended only if the patient starts to present with neurologic symptoms. So surgery should be considered if tissue is needed because there isn't a clear primary. The met is greater than 3 centimeters in diameter. If the met is the source of the patient's neurologic symptoms, if it's in the posterior fossa or the back of the brain because it can cause obstructive hydrocephalus, or if it is cystic or necrotic because they don't respond well to radiotherapy. And patients usually get an MRI within 48 hours after surgery. And within 2 weeks, they start stereotactic radiosurgery to the resection cavity, along with any other mets that weren't resected. Whole brain radiation used to be the mainstay of care, but now really stereotactic radiosurgery has taken over. We were trying to think of some specific instances where patients would get whole brain, and it's very rare, I think, at least where we were at, that was still occurring. And so these patients will also start systemic therapy that is specific to their cancer type. And we usually see them for their initial post-op visit and as needed, but their care really gets taken over by radiation oncology and medical oncology. So this was a woman in her 50s with metastatic breast cancer. She had a seizure and was found to have a large left frontal temporal cystic met, which is coming up right here. And so since the met was large, it was cystic, and it was the source of her neurologic symptoms, she underwent a cranioresection, and we achieved a gross total resection. I apologize, I don't have the post-op for this patient. But that's a picture of her incision with the invisible closure. She underwent radiosurgery to the tumor cavity as well as her other mets within 2 weeks after, and then she continued her systemic treatment for breast cancer. So this is actually my husband's case. So this is a 70-year-old male with metastatic lung cancer. He presented with all segmental status and a new left anterior temporal met. He actually underwent CyberKnife pre-op, but due to the size and concern for edema, radiation oncology recommended surgical resection. And so he had a gross total resection, and my husband actually did this through a mini craniotomy. And he left the hospital post-op day 1 per the patient's request, minimal soreness at the surgical site, and his mental status had improved. So in addition to brain tumor resection, there are other ways neurosurgeons can help oncology patients. Sometimes tumors may be in a location that can cause hydrocephalus. Like I had just mentioned previously, one of the indications for METs is in the posterior fossa, and it causes obstructive hydrocephalus. So we can insert shunts for CSF diversion. And along those lines, sometimes patients may need drugs administered directly into the CSF space. And so we can also place Ommaya reservoirs to help out with that. And both of us do this regularly for patients. So now I'm going to switch over to spine tumors. So primary spine tumors can be within the spinal cord itself, within the dura, around the cord, around the nerve roots, and it can also be in the bone. I put green boxes around the different examples in the diagram here. So for primary tumors, downstream therapies are generally dictated by the extent of resection. So for example, if you have an astrocytoma, which is intertwined with normal spinal cord tissue, you may only do a biopsy or at best a subtotal resection, and therefore you have a higher reliance on downstream treatments. On the other hand, if you have a tumor such as an ependymoma, where you can achieve a gross total resection, or a chordoma, where you can do an en-bloc resection, then you're able to monitor for recurrence before starting downstream treatments. It used to be for some of these, especially chordomas, that we would go straight to proton therapy after resection, but there were a lot of wound healing issues with the patients. So we found that if we were able just to monitor them, they actually did better. So as an example, this was a patient in his 50s who was experiencing some neck pain while golfing. He saw a neurosurgeon who did a biopsy and closed. The biopsy came back as an ependymoma. So, looking at the imaging, even though the tumor is contained within the cervical spinal cord, it's pretty distinct, at least in my eyes, from the cord, which is typical of an ependymoma. So a gross total resection could be achieved in this patient. And so we took him to the OR. This is a view through the microscope. That's the spinal cord. You can see the hole in the back of the spinal cord where the prior neurosurgeon did the biopsy. We just expanded that hole here. And as the tissue opens from the spinal cord, you can see the tumor right there within the spinal cord. And so basically you just separate it from the regular spinal cord tissue. It's out. We're just working on getting hemostasis right now. And these are special bipolars that really, they're more targeted with their cauterization. So this is what we typically use when we're working with spine tumors, intramedullary spine tumors, so tumors within the spinal cord. And then you just close up the dura when we're finished. So for follow-up, we do MRIs at 3 months and 6 months, and then yearly. On his 3-month MRI, there was a gross total resection, no evidence of recurrence. So he's monitored for now. In the image that's on the left, that's artifact. So usually with these patients, I do a laminoplasty because I don't like to put hardware in patients unless I absolutely have to. But this poor gentleman, because of what had happened with the prior neurosurgeon, we needed to put hardware in his back. So that's just artifact in that picture on the left. So the mainstay of treatment for certain primary tumors of the spine is en bloc surgical resection. And what that means is that the tumor has to be taken out in one piece with a rim of regular tissue around it. So the problem is that these tumors are usually in high real estate areas. So taking tumors out in en bloc resection carries a 36 to 83% complication rate, depending upon the site of the tumor. This is probably the most morbid types of surgeries that I do. So one of the new surgical advances to help mitigate this is called augmented reality. It's a headset that overlays the patient's imaging over the surgical site. And you can see I'm on the right in the picture all the way to the right with the headset on. And then you can also see the images there of what it looks like when you're looking at the patient. And this really helps us to plan and perform precise tumor cuts to minimize damage to surrounding tissue. And so I'll show a case example. So this patient I saw was a very young, very active woman who was just experiencing lower back pain. She was found to have a sacral chondrosarcoma, which is a very aggressive, very malignant primary bone spine tumor. The tumor was encasing her sacral nerve roots, which are in the right arrows on the left. And so those nerve roots will have to be sacrificed if we take the tumor out. However, some of her lower lumbar nerve roots were draped over the border of the tumor. And that's the intraop photo on the right where we could see the nerve roots with that white arrow draped over the tumor. So typically with these types of surgeries, we would have had to take all of these nerve roots out, and it would have caused significant neurologic compromise like weakness, bowel bladder incontinence, and a young active woman who just had presented with back pain. And we would have had to take a larger portion of her sacrum, which would have further contributed to spinal pelvic instability and really would have worsened her quality of life. However, with the use of the intraoperative navigation to improve planning, we're able to plan these exact cuts that you can see in the diagram here for what's called a left-sided hemisyncrectomy. And having the overlapping imaging in the OR along with navigated instruments, we're able to efficiently execute this plan. So we ended up only having to take her S1, S2 nerve roots, which causes a very minimal neurologic compromise. And if you can see in the image on the right, the tumor came out in one piece with negative margins. And then here we did a spinal pelvic reconstruction, which was much smaller than what typically has to be done in these patients. And she didn't have any postoperative chemo or radiation because we got good margins on the resection. And a 9-month follow-up, she was almost back to her fully active baseline. She wasn't having any issues with bowel bladder function, and her MRI looked clean. And that's really the power of the new technology that's coming out now to be able to help these patients. So finally, I'll switch to talking about treatment for metastatic spine disease. So spine metastasis treatment has an interesting history. Initially in the 1970s, treatment was less invasive surgery with higher reliance on radiation treatment. And that was because spine fusion wasn't very popular at the time. So many patients had unstable spines and their outcomes weren't too great. And overall, the treatment wasn't good because the radiation option was only conventional external beam, which wasn't targeted like the stereotactic radiosurgery is. So a lower dose would be used to spare the spinal cord, and recurrence rates were high. And then fusion hardware started to become more popular, and MD Anderson released a study showing that more aggressive surgeries with fusion could overcome some of the limitations of the, I'm going to call it CEBRT, that's the conventional. And then there was this famous Patchell study which showed that surgery plus radiation is better than radiation alone for treatment of these tumors. But now the pendulum's starting to swing back towards smaller surgeries, and I'll explain why as we go through. So the development of spine stereotactic radiosurgery has really changed the radiotherapy paradigm. The ability of SRS to deliver an ablative dose that's histology and size independent has changed the indications for and the types of surgeries required. And this really surpassed the ability of the CEBRT, which is limited in delivering tumoricidal doses, as I said, without risk of port injury. And there was a multi-center randomized controlled trial that compared the conventional external beam to stereotactic and showed that stereotactic was superior in improving the response rate for painful spine mets with no difference in treatment-related adverse effects. And in another study showed local disease progression in patients who underwent surgery plus the adjuvant stereotactic radiosurgery. And they found local progression rate at 1 year after treatment was as low as 4.1%, depending the dosing, which is great. So with these new advances, the treatment pendulum swung back towards higher reliance on radiation therapy as an effective treatment, and surgery really is used in selected cases as an adjuvant therapy for recovery of neurologic function to create separation between the spinal cord and the tumor for radiation planning and for spinal reconstruction if the spine's unstable. So currently, the most used treatment algorithm is called the NOMS treatment algorithm, which stands for neurologic, oncologic, mechanical, and systemic disease. And I'll go through each of these step by step. So the neurologic assessment considers both clinical and radiographic parameters, including the presence of myelopathy, functional radiculopathy on exam, and then the presence of epidural spinal cord compression on MRI. And there's a 6-point grading scale for judging the degree of epidural compression, and this was validated by the Spine Oncology Study Group. It's normally called the Bilski score, and you can see it in the middle right there. And so in the absence of mechanical instability of the spine, you know, if you have a lower Bilski score, meaning there's not as much compression on the spinal cord, these patients may be considered for radiation treatments first. Whereas if you have a higher Bilski score and there's more compression on the spinal cord, you know, then these patients usually undergo surgical decompression prior to their radiation therapy. And then there's a kind of a gray area. This is why I say these things are all nuanced. And this is why it's always a discussion with medical oncology and radiation oncology, you know, where it looks like there may be some spinal cord compression, but the patient may be able to just do radiotherapy and save themselves a surgery. So the oncologic portion considers tumor responsiveness to radiation therapy based upon histology. So tumors are considered sensitive or resistant. Lymphoma, myeloma are uniformly classified as radiosensitive. Multiple studies actually support the use of still using the CEBRT to treat these tumors, regardless of the degree of epidural compression or neurologic deficit. We would still do this at Hopkins too. You know, the radiation oncologist would still use that in some cases and then reserve the stereotactic radiosurgery for other cases. In most cases, radiosensitive solid tumors, such as small cell breast, prostate, ovarian, they'll be treated with CBRT alone, even in the cases of high-grade epidural compression. And, you know, this is because even though the conventional can cause spinal cord toxicity at higher doses, it still has good potential for causing mitotic cell death, which means that it allows the tumor to collapse within itself without much damage. So if you have a tumor that's sensitive to this and you don't require as high of a dose, it still is a viable option. You know, and there's still some exceptions to this where patients would require surgery or stereotactic radiosurgery if they failed the CEBRT before. And that's why I kind of put this as a dashed line. So in radioresistant tumors with low-grade compression and no neurologic deficit, stereotactic radiosurgery is sufficient as first-line treatment, which is a departure from the previous treatment paradigm where these patients would have just been referred for surgical resection. And the radioresistant tumors with high-grade cord compression, like those higher Bilski scores I was talking about, they will require decompressions, you know, what's called a separation surgery, infusion prior to stereotactic radiosurgery. So the mechanical deals with the stability of the spine, and mechanical instability is defined as by the Spine Oncology Study Group as an indication for surgery independent of the degree of epidural compression. So meaning that even if someone has a low Bilski score, their spinal cord's not compressed, but it looks like they have instability of their spine, we still would recommend them for surgery, not so much for any decompression, but to put hardware in to stabilize their spine. And so we use a scoring called the SIN scoring system to assess for instability. It's based on radiographic and clinical criteria. We look at the location of the lesion, patient's pain level, their alignment, how much their vertebral body's collapsed, if the posterior elements or the back of the spine is involved. And clinically, it's important to recognize that there's a difference when we talk about pain between mechanical pain and tumor-related pain. So mechanical pain is movement related, and it can be helped with surgery. But if patients have tumor-related pain, that's usually present at rest, and that's really helped with radiation therapy and with steroids. And so this really helps to categorize patients from a stability standpoint to see if they would benefit from stabilization. And finally, the systemic. So all decisions about surgical intervention are taken into the context of whether the patient will be able to tolerate the procedure based upon their other comorbidities and the degree of their systemic disease. And one example that's used for this assessment is called the SWORD nomogram. It uses several metrics to prognosticate in patients with metastatic disease, and it's been found to accurately predict 3 and 12-month survival. And so the recommended postoperative survival is greater than 3 months. So if we have a patient that have greater than 3 months survival, then we would consider them for surgery. In patients that have less than that survival period, we really have to have a discussion about whether they should have the surgery due to, how long it would take them to recover. But the one thing I do want to note about this is that 3-month timeline was proposed before the advent of minimally invasive surgical techniques, some of which I'll show in my examples. And so, as it stands right now, it's a little unclear about what degree expected survival should influence candidacy, which is why I said we have to have a discussion. So this is a 51-year-old female with non-small cell lung cancer, had undergone a previous lobectomy, chemoradiation treatment, had known brain mets with prior cranial stereotactic radiosurgery, presented with progression of a known thoracic lesion. Because she had a high-grade Bilski 2 epidural cord compression and a radio-resistant histology, and was otherwise healthy with a prognosis greater than 3 months, she was recommended by the tumor board for separation surgery. And so we took her to the OR, we resected the tumor, decompressed her spinal cord. We only took out tumor that was directly compressing the cord. We also stabilized her spine. I use carbon fiber hardware, which reduces the artifact for post-op radiation. And then one of the new advances I had mentioned earlier in these types of surgeries is the use of robotics, which I had been very heavily involved in and helped really pioneer at Hopkins. And, as you can see here, the surgery is completed through a series of small wounds. And this is different than prior when we used to do these huge, large incisions down the back of the patient. And this really helps with wound healing, and it allows the patients to receive postoperative radiation sooner after surgery. So this patient went for stereotactic radiosurgery within 2 weeks after surgery. And then she was also on immunotherapy for her systemic disease that she was able to continue throughout the course of the surgery. And I also have a lecture on the use of robotics and augmented reality for spine tumor surgery that's on the YouTube channel for the Seattle Science Foundation, and it goes into this a little more specifically. And so I just wanted to quickly add this in here when speaking about systemic disease. Although the exact mechanism isn't completely understood, it's thought that local stereotactic radiosurgery can impact systemic disease in cancer patients, as multiple studies have shown improved survival. And one thought is called the abscopal effect, where local irradiation of a tumor can lead to immunogenic forms of tumor cell death, meaning that when a tumor cell dies, tumor antigens can be processed by the immune system, and that immune system can go and circulate throughout the bloodstream and destroy other tumor cells in distant parts of the body that weren't irradiated. And one of the largest studies was the SABRE COMET trial, which showed that in 99 patients that were treated with stereotactic radiosurgery, they had both improvement in overall survival and progression-free survival. So over the past decade, there's been advancements in percutaneous techniques to ablate epidural disease using different targeting schemes. And these are really reserved for patients who can't tolerate surgery or have focal disease and no instability. And additionally, one of the other options as neurosurgeons that we can do to help cancer patients is put in intrathecal drug delivery to help with pain. And that's something that, I'm also a huge advocate of to be able to help these patients. And the last thing I want to mention, which I think is very important, is just to talk about kyphoplasty. So kyphoplasty stabilizes pathologic compression fractures and relieves mechanical pain. There was a study done called the CAFE study. It was a randomized controlled trial in over 22 sites, and it provided evidence for this, showing that in patients with pathologic fractures who underwent balloon kyphoplasty at 1 month post-procedure, there was a decrease in using braces and walking aids, there was a decrease in bed rest, and there was a decrease in the use of pain medication. And additionally, when comparing vertebral body height restoration, this was significantly higher in the kyphoplasty group. And the reason why that's important is because when a patient gets a compression fracture and it continues to progress, it starts to cause them to lean forward, which is called a focal kyphotic deformity. And if they get to the point where they're too far forward, it can cause compromise to their spinal cord. And once they get to that point, that requires a very large surgery to reconstruct their spine. And it's something, and usually these patients are older. And so that's something I don't like to do, especially in older patients and especially in cancer patients, especially when you can do something, as minor as a kyphoplasty to help prevent those downstream effects. So finally, just to follow up, I talked about a lot of things today, and as you can see, treatments are very nuanced, but the main things are for brain and spine tumors, it's surgery, radiosurgery, systemic therapy. And the other big thing is that these decisions are not made in a silo by neurosurgeons. It really requires a team with radiation oncology, medical oncology, radiologists, and usually there's a tumor board and you evaluate these patients on a case-by-case basis, and you go over all these different treatment options and you see what's best for each patient. Thank you, and this is our team. It's myself, my husband, and our PA, Liz.
Thank you very much. That was excellent. It's obviously you guys bring an incredible skill set, and so we're glad to have you in Southwest Florida. Before I open the floor to questions, I just, in honor of Women's Health Month, wanted to mention that I have a picture here of Dr. Cecino with 3 of her fellow graduates from the Hopkins residency program in neurosurgery from earlier this summer. And the interesting thing is all 4 were women. And so that's the first time, I think, in Hopkins history that all 4 graduates were women. So congratulations. Are there questions?
So that was a great talk, and you talked about a lot of new things. Are those things available here at MCH?
So everything for the cranial procedures is available here. As a matter of fact, 2 weekends ago, my husband and I did a craniotomy with an invisible closure on a patient. In terms of the things for spine, the types of surgeries I am able to do with the navigation systems that are here. One of the things that I'm trying to bring to the region is robotics with the augmented reality. So I've been trying to talk to the administration to see if that's something, because there definitely is the support from the hospital to be able to incorporate that into the OR. So that's something that I'm hoping we'll be able to bring down here.
Thank you very much. That was great.